those of you that don't know me, my name is Faith. I'm the clinical lead for MPFT's Adult Eating Disorder Service, and Rob is somewhere.
Yeah, I'm here. I'm the consultant and lead, one of the consultants. I think Dr. Jackson, the other one, has sneaked onto this afternoon. So I'm one of the consultants covering Shropshire, and I'm also the clinical lead for the provider collaborative with the eating disorders one.
So I'm going to take everybody through a bit of a presentation. It's a really broad topic. So we've tried to sort of give some key information and some of the most the things that we think will be the most helpful pieces of information to share. What I'm going to do now is, hopefully with some success, share the presentation to everybody and hand over to Dr. Dennis to start, if that's okay.
Broadly, what we're going to be talking about. So we're going to start off by talking about the eating disorders. These are the things that our service treats. Now, I'm not going to say sort of commissioned to treat or anything like that, but the eating disorder are the things that we have an experience and an expertise in being able to treat. When we move on to the things that we often get involved with, but we're not the primary deliverers of the therapeutic treatment. And so we're going to move on to talk a bit about disordered eating, which, as you can see, is this much broader term that describes a wide range of difficulties with eating. And so really what we're going to be saying is not everyone that's got difficulties with eating necessarily has an eating disorder that we're going to be able to treat, but we're still going to be able to sometimes, offer advice depending on what the underlying pathology is. These things can always end up quite monotonous if we're not careful. So I am quite happy to field questions as we go along. And I'm sure Faith will be too. So the more conversational we get this, I think the more interesting it's going to be for people. So don't feel shy about putting your hand up and asking a question. No such thing as a daft question. And it could be that, Faith or I say something that you think is really contentious and that you want to challenge us on straight away. And I think by and large, we're fine with accepting challenges. I think it depends on the question. I might live to regret that statement, but just don't be shy. Just put a question up and ask away. So what I'm going to do on the next slide is we're going to talk about the eating disorders. Now, there are three on the left, which you can see: anorexia, bulimia, and binge eating disorder. And then there's one on the right called ARFID, and that stands for avoidant restrictive food intake disorder. And as you can see in the little brackets underneath, it says it's a feeding disorder. So it's one of those conditions that none of our services were originally set up to treat, but because of some of the difficulties that these patients present with, we've ended up de facto being the teams to run point on the treatment for patients with ARFID. But there is a really significant difference between their presentation compared to the main three eating disorders. And the thing that unites, I've got to say, it's really off-putting, the number of pop-ups that keep firing up saying admit, and I think, do I have the power to press deny? So, but I won't. I will keep my hands away from denying people entry. So the three on the left, which are the eating disorders that we particularly specialize in, and they're all united under an umbrella of the psychopathology that underpins the condition. So what I mean by that is that the beliefs that underpin the patient's difficulty are all really very similar. And it's the manifestation, the behavioural and physical manifestation of the condition that changes depending on whether it's anorexia, bulimia, or binge eating disorder. So the first thing that it's probably worth thinking about, because it's what we always look for in a referral, is, does this patient have the psychopathology consistent with an eating disorder? And the first thing that you can see is every patient there is either restricting their diet or is restraining their diet. So dietary restriction is roughly the successful limiting of the amount that you allow yourself to eat, whereas restraint is trying to limit the amount that you'll allow yourself to eat, but being much less successful in it. So for all of those things, though, what the patient is doing is deliberately trying to limit what they'll allow themselves to eat. And that is always driven by a motivation. And it's that motivation that is the core of all three of those eating disorders. Roughly, that can be split into a fear of weight gain, a distorted body image, and an over-evaluation of weight and shape. So those three statements are all really easy to say, but what does it actually mean? So fear of weight gain is sort of quite self-explanatory, except it's a bit more, like all of these things, it's a bit more subtle. Often people will expect patients with an eating disorder to be saying that they're attempting to lose weight, whereas actually that's a relatively unusual presentation, and it's something that, again, will immediately alert us to perhaps there is a different explanation going on and not one of the major eating disorders. But what the patients will describe is, I'm really frightened of gaining weight, but not this desire to lose it. Now, the reason why someone will be frightened of gaining weight is because the other psychopathology. So the other one that we mentioned is a distorted body image. So this, in all of your sort of textbooks, will say patient thinks they're fat when they're not. And that's sort of a rough thumbnail sketch of that's sort of correct, but it lacks the sort of the nuance and subtlety of what patients actually describe. And so what patients will often say is that they, if underweight, that they will recognize that they're underweight. So most patients that you meet on the Kimber ward where our inpatients are based will say, I recognize that I'm really underweight, but, and it's in the but where you'll find this body image distortion, which is an inability to accurately appraise your own weight and shape. So what they'll say is, I recognize I'm underweight when they've got a BMI of 12, 13 or whatever, but they will assume that they will be fine and normal weight at a BMI of 15. Now, for those that don't know, a normal range of BMI is 18.5 to 25. Now, there are lots of problems with BMI. If you're too short, too tall, if you've just had surgery, all sorts of things, rugby players, anyone, there are lots of problems with BMI. Sorry, there was a question popped up and I didn't see it. So pop your hand up and I'll just answer it. Was this children's and adults or just adults? Well, we're the adult service, so that's what we're here to talk about. A lot of it, so the diagnostic bits is very similar, and a lot of the basic treatment is very similar. Again, some of the subtleties are different between children's and adult services, but by and large, there's more similarities than differences, I would say. Yes, so you lose the ability to accurately appraise your own weight and shape. So patients will think that they will achieve a normal weight when they hit a BMI of, say, 15, but actually we would still consider that to be seriously underweight because the normal range is 18.5 to 25, and that's a very broad church. So you have to work quite hard to get outside of that range. What does that range mean? It means inside that range, your health isn't going to suffer because of your weight. Now, interestingly, a BMI point either side has different effects. So a BMI of 26 is actually considerably less physically dangerous, even though it's 1 point above, than a BMI of 17.5, which is 1 point below. So you accrue health risks much, much faster as you lose weight compared to as you gain weight. And it's quite interesting. There was a big study that was done, 500,000 people in California, middle-aged women. And what they found was that middle-aged women with a BMI of 30, which is the cutoff between overweight and obese, lived on average 5 years longer than those with a BMI of 20, which is low normal. So although we often sort of hear being overweight is unhealthy, that's actually perhaps not as true as we've been led to believe. And that actually being low weight, underweight, seems to be much riskier than being overweight. And so you might have heard in the press, the World Health Organization quite recently is trying to actually rebadge obesity by saying not all obesity is unhealthy. And so they're trying to actually split people into the healthy obese and the unhealthy obese, which is really quite a radical shakeup of what we've been thinking. But this belief that overweight is bad and underweight and slim is good and healthy is part of the reason that underpins that fear of weight gain, because the person will think, well, if I gain weight, I'm going to be unhealthy. But also society is quite judgmental about weight. And society tends to associate quite a lot of pejorative views with people who are overweight. So the sorts of comments will be sort of lazy, poor self-control, unhealthy, unattractive. So there tends to be a lot of negative connotations for people who are overweight. And this sort of feeds into this fear of weight gain through this what was the other bit of the psychopathology, which isn't this over-evaluation of weight and shape. And what we mean by that is that someone puts, no pun intended, far too much weight on their weight as being the source of success and happiness in life. And so when you get people to sort of talk about, okay, what are the things that go to make you up as a person? If you get them to draw a pie chart, and actually in one of the treatments CBT they do, what they'll do is they'll put far too much of that pie chart, they'll colour in as being about weight and shape. So they feel it's the prime determinant of how they view themselves and how other people view themselves. And so you can see that this makes a sort of fertile ground. If you can't accurately appraise your own weight and shape, and you're frightened of weight gain, and society views being overweight as really bad, then that's all sort of a bit of a combination that feeds into this dietary restriction, in that if I'm unhappy about my life or I'm feeling unsuccessful, then I'm likely to be happier and more successful if I was to lose weight, which then leads into the dietary restriction. And so whether it's anorexia, bulimia or binge eating disorder, that same origins is across all of those conditions. So how do we then differentiate between them? So the first one, and it's probably the most important one to know about in our service, would be anorexia. And so anorexia will be the psychopathology that we spoke about, but that dietary restriction has led the person to be underweight. So a BMI of less than 18.5. Now, some of you might go, oh, I thought you had to have a BMI of less than 17.5 to have anorexia nervosa. And certainly that's what a lot of textbooks will be saying. But in the change from ICD-10 to ICD-11, the BMI cutoff was bumped up to being just underweight. So you've just got to be underweight now. So the BMI of 17.5 cutoff has gone. Or we also get some cases where patients have lost more than 20% of their body weight in the preceding 6 months, and that would also be enough to garner a diagnosis of anorexia nervosa as well. So that dietary restriction is leading to significant weight loss, generally so that someone becomes underweight. And then if you're frightened of gaining weight and you think you're bigger than you are, what this then tends to lead to, as well as the dietary restriction, are the compensatory behaviours. Now, in what we'd call pure restrictive anorexia, the compensatory behaviour just tends to be exercise. So we'll often see people, who will be at the gym 5 days a week and running 10K every day, or have to hit their 20,000 steps per day. So for restrictive anorexia, what you get is dietary restriction, and exercise-driven compensatory behaviours. But you also get another group of patients with anorexia, and these are the people that lose control over their eating. And by that, I mean binging. So the true definition of a binge is loss of control over your eating. Now, again, we tend to think of it as eating large amounts of food over a short space of time, often in secret or in solitude, associated with feelings of guilt. And all of that is absolutely true. But the real thing is loss of control over eating. So if you say to yourself, I'm just going to eat 1 cracker, but then you end up eating 3 crackers and you couldn't stop yourself, even if they were Ryvita or Snacker Jacks, and so objectively it's not a large amount of food. If you told yourself you weren't going to, but you couldn't stop yourself, that would still technically be considered a binge. And when people lose control over their eating like that, what that will often lead to is a different sort of compensatory behaviours, which would be it's interesting. I saw the shocked face there. There's a brilliant example about a famous celebrity that I was going to say, but then I saw the little red record button going on, and I thought, I'm not going to dob this celebrity in it, just in case I get a call from trust solicitors or something. So I'm afraid a much better anecdote about a true subjective binge, we'll have to wait for an in-person lecture, I'm afraid. that loss of control over eating, that binging, leads to a different suite of compensatory behaviours, which we tend to refer to as purging. Now, of which the most common one is self-induced vomiting. And you can see that lovely little sort of graphic of the toilet. And the bottom left one, would be sort of pills. So either dieting pills, particularly sort of stimulants, so amphetamines, cocaine, things like that, but also laxatives as well to help with the purging. So laxatives and stimulants are the other sort of pills and that people will take to try and suppress and use their weight and purge themselves of what they've eaten. And the eagle-eyed amongst you will probably be thinking, oh, I bet, are you having problems with Mounjaro and Ozempic and all those GLP-1 agonists? And the answer is yes, we're beginning to really see it now. Sort of two camps of patients: those that had a previous eating disorder that get their hands on this, which causes really terrible weight loss. But we're also filling out a number of yellow forms via the back of the BNF at the moment, are those with no discernible eating disorder who started particularly on Mounjaro, actually, that we're seeing the most of, who then develop all the symptoms of anorexia, real dietary restriction, real fear of weight gain, an absolute terror of coming off these medications. And a lot of them have lost over a third of their body weight. So meet the definition of the diagnosis of anorexia now. Do I think these injections will be the new addictive drug for our services? Yes, I think, if you'd asked me a year ago, I probably thought the risk was overstated. But with the number of referrals coming through now and interviewing patients taking these things, they're very, very effective, and people lose a lot of weight. And even the best case scenario patients will say, I'm really happy with my weight loss, happy to move to maintenance, but I can't come off these medications. I'm absolutely terrified my weight is going to roar up out of control. And so I think we are going to run into problems with it. It's going to be really interesting to see now the price of Mounjaro has gone up by 170%. So what was previously about £100 a month is now just shy of £300 a month. Again, anecdotally, we're hearing people stocking up on this stuff and shopping around lots of different online pharmacies. I was going to again name and shame the online pharmacy that seems to be dishing it out as most, but again, I saw the little red dot of the recording and thought, I'm not going to name the online pharmacy. But yeah, I think it is going to be a big issue. So Faith, have I missed any compensatory behaviours?
I was just there's a question just above that question that you've just missed. I think they came in very close together.
Fear of eating, avoid foods, but also have some of the other symptoms. Yeah. So once we've finished the anorexia, bulimia, and binge eating disorder, I'll move on to ARFID, and that will absolutely answer your question. So what we were describing was binge purge anorexia. So it's all of the psychopathology of the eating disorders, dietary restriction, loss of control, leading to purging behaviours, most frequently vomiting, and your BMI is under 18.5. If, however, your BMI is in the normal range or above the normal range, and you have all of those symptoms, you would get a diagnosis of bulimia nervosa. So the only difference between binge purge anorexia and bulimia nervosa is your BMI. And so if we did a telephone consult, a telephone assessment, and someone gave all those symptoms over the phone, I wouldn't be able to tell the difference between binge purge anorexia and bulimia. It's really the only difference. And of course, that means gaining a couple of 100 grams or losing a couple of 100 grams can alter the diagnosis of anorexia and bulimia. And that intuitively doesn't sound right. Why would your diagnosis, why would your illness change by gaining, a couple of 100 grams? Common sense says that it wouldn't and that it shouldn't. But that's our diagnostic criteria at the moment. And that belief sort of led to what's called the transdiagnostic theory of eating disorders, which is the psychopathology is the same across all of them. Therefore, all eating disorders are fundamentally the same. And that led to development of one of the treatments we're going to talk about, which is CBT-E, which was really effective. The bit that sort of called into question that transdiagnostic theory, though, was that CBTE was really good for treating binge eating disorder, bulimia, and some anorexia, but it was much less successful in treating anorexia than it was in bulimia. And that's probably due to the cognitive processing style of patients with restrictive anorexia, who share a commonality with some of the other sort of high impulse control conditions like OCD and autism spectrum conditions. And you can't really change your processing style, which is probably why the treatment is less effective. I don't think we've got time to go into the links between autism and anorexia at this moment. But if we get time at the end, more than happy to sort of go over that a little bit. So that's anorexia, that's bulimia, and binge eating disorder then is exactly the same as anorexia and bulimia. You've got the same psychopathology, you restrict your diet, but you're just overall much less successful in restricting it. And the binging is much more frequent, and you also don't have the same compensatory behaviors. So people aren't underweight, they tend to start off normal weight and then just gain weight as they go through the illness. Because as we know that, you know, diets aren't effective. So those are the three main eating disorders, and that's what we mainly treat. There's also this one sitting on the right called ARFID, which is this avoidant restrictive food intake disorder. And patients lack the psychopathology of all of the other eating disorders. So they don't have the same belief system. They don't over-evaluate weight and shape. They don't have a fear of weight gain, and they don't have body image distortion. So they don't have any of that. And they don't deliberately try and limit what they eat in the same way. But what they do have is isolated sort of difficulties with eating. And roughly they split into three camps. So the first camp, probably the hardest to treat, are those that have people that have a complete disinterest in food. And we've got some patients that have got down to extremely low weight just by never bothering to eat. They say, don't really feel hungry, and I'd always rather be video gaming, or I'd rather be out with my mates, or I'd rather be playing football. And I come in and people say, do you want dinner? And I go, no, not really. And just wander off. And so they just don't prioritize eating. Now, if you put food in front of them and say, look, you got to eat, they'll go, oh, yeah, all right then. And they'll eat it. So we had one chap who was a middle-aged chap, very underweight. First day he walked onto the ward, was handed his menu, and he went, oh, I think I have pizza and chips, please. And that summed up his admission. He'd just go straight into the dining room and wolf his way through the least anorexic sort of foods that you could possibly imagine. And that's the true disinterested ARFID style. Then you have the other group in which it is much more associated and linked with the autism spectrum conditions, in which they avoid certain sort of tastes, textures, colors. So won't eat crunchy foods, or will only eat beige foods, or, you know, won't allow foods to mix. So they'll have really sort of strict rules about what they can eat, mostly driven by sensory issues, highly associated with autism. And then the third group are those that have had, as it says here, an adverse outcome with food. So perfect example, we had a young woman who had gone on holiday with the school on a New York trip to see the Guggenheim Museum or whatever it was. And whilst she was there, she got diarrhea and vomiting, but they were due to fly home. And so the school said, look, you're just going to have to take a load of Imodium and just hope for the best on the plane, because we can't abandon you. This isn't Home Alone. We can't leave you, in a hotel in New York as a 15-year-old on your own. So they got her onto the plane, and she proceeded to, there's no polite way to put this, vomit and shit her entire way through the flight, much to the both horror and ridicule of all of her classmates. And as soon as she got back, she couldn't eat. She would only eat foods directly from out of a packet. So if it had a use by date, she wouldn't touch it. She'd only eat something that had a best before date. Anything that had any chance of making her ill, she just wouldn't eat, because she had been so mortified and traumatized by this experience on the flight. And she ended up with a BMI of down at 13. And because when we first met her, she'd just come out of CAMS services, and so had spent time in the general hospital. Fully recovered now, though, which is great. But that's this style of ARFID. They're so worried about the effect of food on them, so vomiting or choking or things like that, that they'll steer clear of it. But it's slightly different from a simple phobia. Right. So those are the main eating disorders. Shall I ask Faith if there are any questions about what I've spoken about so far? Because I recognise I've barreled through it at a really fast rate.
I don't have any questions. I knew all of that, but it was very interesting. Has anybody got any questions they wanted to ask about the diagnoses or any of the different eating disorders? I'm going to assume silence is a no, rather than asking you all to say, "Oh,
right, yeah."
Not very good at this, am I?
Are there links between eating disorders, specific types and changes to hormones linked to hunger eating behavior, so ghrelin and leptin? And the answer is yes, but it's extremely complicated. And one of the problems with the treatment of anorexia in research is that in order to be a case, you've got to be underweight. And the definition that we've heard of being underweight is that it has to affect your health. So when you do any investigation on someone who's underweight, you're never certain whether it predated the eating disorder or whether you're seeing a complication of it. A silly example, well, it's not a silly example, but a very true one, is that if we do a CT brain or MRI brain on any of our patients, they all come back with cortical atrophy and enlarged ventricles. Now, is that a result of malnourishment, or is it the cause of the eating disorder? So the only way that you can find that out is to treat the patient successfully and then rescan them. And treatment in the first sort of 2 to 3 years only has about a 30% success rate. So you very rapidly get to very small numbers, and holding on to people in a research study for 3 to 5 years. And actually they say you need to do the follow-up studies 5 years after complete recovery to really work out whether something has properly returned back to normal. Now, when it comes to the brain structure, it does return to normal with weight restoration. So 5 years post-recovery, a brain MRI will be normal. And likewise, but leptin, we don't know actually, but it is abnormal. And so what happens is that the leptin levels in the cerebrospinal fluid are too high. So they are telling the body that it has a higher percentage of body fat than it actually does. But we don't know whether that's the cause of the eating disorder or just a complication of it. But yes, you're right. But it's so intertwined and so complicated. We're just, picking our way through it at the moment. I can see there's a hand, which is at Sarah, but I can't see your surname. Just chip in with your question.
I wanted to know, can it be transferred from parent to child?
I would reframe the question slightly. So the single biggest risk factor for developing anorexia is genetic, yes. But it's still very rare, and most times parents won't necessarily have an eating disorder themselves. So it's a bit like, both parents can have brown eyes and the kid still pops out with blue eyes. So it's genetically mediated, but the parents won't necessarily know that they carry the genetic vulnerability to the eating disorder. So about 70% of the risk factor is genetic. Probably a bit less for bulimia, but about that for anorexia. And the other big risk factor is personality type. So driven, competitive perfectionists tend to be much more vulnerable to developing an eating disorder, which is why, patients with eating disorders will often be seen as sort of very successful people, and they are, because the personality type that makes them really successful, unfortunately, is the bit that makes them vulnerable to the eating disorder, because perfectionism robs people of their self-esteem. So even though to externalize, they're looking really, really successful, to their own eyes, they're always judging themselves as failing. But what's really interesting is that we don't find, so anorexia is not a new diagnosis, and you can find really, really good evidence for it going back 1,500 years. But what you can't find it in is in the sort of Greek and Roman times and before. seems to be arrived at when the monotheistic religions arrived, and whether it's Islam, Judaism, Christianity, all of them at their heart will have fasting somewhere as being seen as a good thing. So fasting is often seen as a sign of, of moral strength, that you prove your worth through self-denial, and that seems to have stemmed from religions. And if you think about it, of the 7 deadly sins, you've got, sloth, gluttony, and lust. So the pleasures of the flesh in religions are often seen as bad things, whereas the Greek and Romans didn't view them in that way. They were things to be celebrated, and they had their own gods for lust and gluttony, and they didn't seem to have eating disorders in the way that we think of them, but now we do. So yes, it's mostly genetic. Environment does play a role, and so does personality, but it's not transmitted directly in the same way from family to family. Does that sort of answer your question?
Yes, thank you.
That's all right. Next slide then. How do we treat people? Well, the mainstay of all of our treatments are the psychological therapies. So they can take place inpatient, outpatient, day patient, but we aim for outpatient treatment where at all possible, because an outpatient recovery that happens as an outpatient, is a much more effective one. There are lots of different therapies that have been tried. They all have about a 2/3 success rate for bulimia and binge eating disorder, and about a 1/3 success rate for anorexia nervosa. They're saying that's probably due to this sort of underlying processing style and difficulties in the anorexic illnesses. They're all about the same. They do seem to be getting better and better though, but we still haven't had an absolutely massive breakthrough. At the 10-year post-diagnosis, about 80% of patients will have recovered, 85%. But that's 10 years. And as I said, after 2 years of diagnosis, only about 30% of people have recovered. So you've got a long period of time, where people are quite significantly ill, and still anorexia still has a high, mortality rate. Now, some patients, if they're not too debilitated or risky with their illness, we will return back to their GP to say, look, come back when you want to do a treatment. Whereas there'll be many patients whose physical risk is too high for us to sort of fairly land in primary care, and we will keep those in our monitoring clinic. And so we will just do sort of keep in touch therapy, keeping an eye on their physical and mental health, ready for when they do feel able to embark on another round of psychological therapy. So that's sort of outpatient therapies. And so inpatient treatment, broadly, we've got 2 reasons for admitting people. One is the sort of full-blown recovery admission, and as you can see, that's about somewhere between 6 to 8 month admission. And then you've got medical stabilization admissions. So this is when people's physical health has deteriorated so much that it's just unsafe to manage them in the community, and we'll bring them into hospital and we'll treat them. Generally, that average length of stay is about the combination really of of both a lot shorter inpatient admissions and some lot longer recovery ones. So across our entire inpatient stay, length of stay is about 110, 120 days. But there'll be lots of patients that are in and out within about 6 weeks. Sarah.
Is the treatment different depending on which it is, whether it's anorexia, bulimia, or is it all just the same?
The first line treatment for most of them is variants of CBT. So one of them was called CBTT, and that's a 10-session treatment, which is for bulimia. So, and people, you're 2/3 cured within 10 sessions of CBT. The CBTE is a longer form treatment for between 20 to 40 sessions, which tends to be used for people who are underweight, because part of the treatment is weight restoration for those cases. So they'll be having a variant that takes longer to do it. Mantra and SSCM are both for anorexia nervosa. Guided self-help tends to be for binge eating disorder and bulimia, and systemic and systemic family therapy tend to be for anorexia for the younger cases, younger patients.
Question in the chat around, does CBT work for autistic and ADHD patients?
Yeah, there's no reason why it shouldn't or can't. And so we wouldn't not offer CBT to someone with a diagnosis of autism spectrum condition.
The treatment missing off the list is CBCAR as well, which is the CBT-based treatment for ARFID.
Specifically for ARFID, absolutely. So that was inpatient. So we've just done inpatient. So I don't think there's much more, reason to talk any more about that. So we're about to move over to disordered eating. And so what we said is that everything we talked about, apart from ARFID, has been, the motivation, that drives this behavior, that fear of weight gain, distorted body image. And those patients are, deliberately choosing to not eat enough because of those reasons. But there's a whole host of reasons why patients might either not eat or be low weight. And that's a selection of them. So, and some of it's sort of quite obvious. If you've got a significant, opiate addiction, patients don't prioritize food, they tend to be low weight. Significant alcohol problem, don't absorb food as well, tend to end up underweight and malnourished. Patients with depression, that self-neglect of the depressed person, appetite loss, low weight. Dementia, poor self-care, poor self-neglect, can't remember to eat. We've had a number of people that we've assessed that we've ended up diagnosing frontotemporal dementias or Korsakoff's because they're low weight, because they're not eating. So you can see there are lots of reasons why people, will end up with disordered eating. So some are, due to things like I said, there's depression, substance misuse, but some are about emotional regulation. And very quickly, I'll just sort of introduce you to that. Food is great. It's why people, comfort eat. Food manages your emotions. Hence the cliche, post-relationship breakdown, eat some ice cream. Because eating is nice, it makes people feel better. It's used as a comfort. But also, paradoxically, not eating makes people feel better. You get a bit of a ketotic high from it, but also, if you're worrying about something that you don't feel able to manage, if you stop eating, your instinctive bit of your brain will tell you you need to prioritize food. So if you were worrying about a relationship breakdown or a problem at work, if you stop eating, all you'll think about is food. But you'll know that if you chose to eat again, you'd be all right. Therefore, the thing that is worrying you then, food, you have control over in a way that you don't have control over the problem at work or the problem with the relationship. And so you can see that both eating and not eating can be used to manage emotions. And with that wonderful segue, I will hand you over to Faith.
I'm going to hand back quickly the question around waiting lists for inpatient treatment because of the length of stay, because that feels very much as the lead clinician for the Provider Collaborative, your question to answer quickly before I go on to.
Yeah, super quickly. There is no waiting list that you would think of. So currently we operate as a Provider Collaborative, 5 units. We've got about 55 beds within the region, and if at the end of this meeting I'm off into our bed management meeting, and if there is someone sort of presented to a medical bed that is ill with an eating disorder, we would be able to admit them Monday. So there's no, to all practical intent, there's no waiting list. But we do it on a needs-led basis, which is about physical health, rather than a sort of first one in, first one out sort of thing.
Focusing on restricted intake as a mechanism of self-harm as a sort of area of focus of disordered eating, brought this one to the table really given that this is the area in which we have the most sort of asks for help, we have the most sort of questions around. And I think some of the elements where on the surface this can be more difficult to distinguish from anorexia in particular, where in restrictive intake, in RISH, food restriction, the weight loss, the level of physical risk can sort of emulate what we see in anorexia nervosa as described by Rob. But the difference in restrictive intake as a mechanism of self-harm is the driver behind it. So where we talked lots earlier in the presentation around over-evaluation of weight and shape, distorted body image and all of those weight shape concerns, the driver in restricted intake as a means of self-harm is around managing and regulation of overwhelming emotions, or a way in which to communicate distress where it's not so easy to discuss or to say. But what it also means is that the treatment approach needs to be slightly different. If we were to import all of the mechanisms of treatment or the structure around care planning that we would employ for the patients talked about with eating disorders, it sort of misses a trick, really. And the sort of broader question to ask in terms of RISH is around what is the function of the behaviour for the individual, where we talk lots about what drives it in anorexia, in bulimia, and in binge eating disorder, all very similarly. This is more around managing those difficult big feelings. As I said, looks very much like an eating disorder until we sort of go beyond the surface. But there is a lot less awareness to RISH than the classical sort of eating disorders that we talked about. And most clinicians in psychiatry are trained to recognise the conditions we talked about in the first half of the presentation, or OSFED, but not this sort of self-harm via restrictive intake. It's not present in the sort of standard diagnostic manuals that we would use. It isn't out there a lot in articles. The history isn't present, like all the really interesting stuff that Rob was able to talk to you about. And that means that a lot of the treatment approaches, lots of the protocols that we have in inpatient psychiatric treatment are sort of weight-focused protocols. Meal supervision, weigh-in, and all of these reinforce the perception to the patient or to us of a sort of diagnosable eating disorder. And patients in the first instance are very often admitted or monitored under the same pathways we would use for diagnosable eating disorders, sort of doubling down on the mishit with classification. RISH patients, like I say, present with weight changes, low energy, anxious affect, which are all sort of symptomatic of being low weight. So if we see patients at low weight, those sort of elements of physical compromise are present as a result of being outside of that healthy weight range into an underweight range. But the reason how that patient has ended up in the situation is often very different. The rapid onset of dietary restriction can resemble the same onset as an eating disorder. So it's easy to understand where sort of first meeting patients, first sort of getting to know them, getting to understand them, construction of formulation, where there's a bit of an overlap and a bit of a crossover, and it can be difficult to decide on the appropriate treatment approach. Has that changed for you? Has that changed? Yeah.
Yes, it has. I was just going to say one thing that I think can be confusing about the title, restrictive intake self-harm, in that the self-harm isn't the goal of the behaviour, it's the consequence of the behaviour. So patients won't be saying, I'm not eating to harm myself, but the harm comes from as a consequence of the not eating. You know, in the same way, when someone deliberately self-harms through cutting, it's not the harm that the harm is the consequence of the cutting, but the goal is to feel better, is to manage that emotion. And I think that the title can sometimes confuse people a bit.
And the table shown on the slide is the sort of where we talked about the differences in the driver behind the behaviour and its purpose. There's also subtle differences in how those can present. Well, some of them are quite distinct differences, but some of them are a little bit more subtle around how patients might present their approaches toward food, how they report their intake. And those are sort of outlined quite clearly in the table. That sort of the initial, food being the centre of most of the risk, most of the concern of practitioners. In anorexia, the approach towards food is very, very controlled. That sort of perfectionistic approach, that sort of high control, that planning, that overthought, the sort of management of fear, being fearful of losing weight, so making sure that intake is lower than the expenditure, very rule bound around the sort of concept of I can't eat. Whereas in in a more of a RISH presentation, that often includes complete refusal of food or denial of being able to eat what they need to eat. Whether you think that's present or it isn't, that will often be the other expression. So that's where we come to that sort of reporting mismatch, that being very overt in RISH, the concerns about restriction, the compensatory behaviours that are engaged in are often talked about very freely, which gives it sort of an ability to be sort of doubled down on and demonstrated. Whereas in anorexia, we're more likely to see a sort of over reporting of intake, and a sort of downplay of risks, downplay of behaviours. As clinicians, we tend to feel more comfortable with what we recognise and what we're able to think about the best strategy for mitigating risk and take an approach. And so where we hear there's a restricted intake, we're often more familiar with the concept of eating disorders. And sometimes we can be vulnerable to selecting our evidence to look for the best fit, and the best fit for a diagnosis. Our care planning approaches, our monitoring and our risk management strategies are much clearer in eating disorders. And the risk is that we see what we recognise and we seek some comfort as practitioners in being able to employ what we think will minimise the risk. I can't see if anyone's got their hands up because of the way the screens are. So if I miss anybody,
No,
just have to shout at me, not at me. So considering our approach when supporting patients with RISH in a different way to how we talked about support and treatment for people with eating disorders, it is more within the same framework of practice that we use in supporting patients with poor emotional regulation, with self-harm behaviours. So that validation, active listening, focusing on safety and coping, that positive risk taking that we would employ more in managing emotional dysregulation, advocating for autonomy in the patient in a way that in eating disorders, treatment can sometimes be seen as more risk averse, where traditionally when we support, if we were supporting around a different self-harm behaviour, we would encourage self-efficacy and containment of distress. Things to be mindful of is robust clinical supervision frameworks, the use of reflective practice, a positive risk-taking culture, and being aware of things that we wouldn't necessarily liken to supporting patients with eating disorders in a way we would need to consider them in disordered eating and RISH. So being mindful of splitting within teams, organisational trauma, so repeatedly dealing with patients where we struggle to be aligned on approach, where we have less evidence behind to support our decision making, altering the way the team feels about patients, thinking about the language that we use. So where we would talk about care eliciting behaviour or attention seeking, and managing that sort of staff anxiety. Very conscious of the time. So this is a sort of smaller rundown of all the things that I've talked about. So presentations that you might see, so a reported lack of intake or a very minimal intake, but what you have is a stable weight. Considering the need for weight monitoring, where we know that the driver behind the presentation is different. Think about how we would monitor other mechanisms of self-harming behaviour. So if you had concerns around self-injurious behaviour, the cutting or burning, would you perhaps use each consultation to review somebody's arms? Very unlikely. So where would we consider drawing the focus to weight? In inpatient care, particularly where you think there's evidence of unobserved eating, that's actually an opportunity that you probably want to create. Remembering all the previous information about food restriction and RISH is usually well discussed. The same with fluid restriction. Fluid restriction is very uncommon in eating disorders and is much closer to a mechanism of the sort of traditional self-harm in a way that we've talked about the differences. In treating of dehydration, evidence of compromise should be clinically evident. The same with malnutrition, really. Going back to that question, is the intervention that we're considering proportionate to the risk? Excessive exercise is interesting in lots of the supporting information and therapies around emotional regulation. A lot of those skills include increasing heart rate, doing exercise as a mechanism to regulate emotions. So being sure that what we're observing and how we're perceiving that is accurate. A positive risk-taking approach. And where it comes to the areas of sort of severe compromise in terms of nutrition, for whatever reason, in eating disorders or in disordered eating, we would always go for a food-first approach, onto oral nutritional supplementation and NG feeding as a last resort. We in eating disorders consider that a life-saving intervention, certainly if done against somebody's will, and consider that as part of a wider formulation. Things like oral nutritional supplementation, IV medications, and NG feeding are communicated as a really strong visual care need, and can sort of double down on a concept of an illness identity. And an exit strategy is really important to any of the management plans, care planning that we implement, thinking about, we often go into management plans with the best intentions. Everything's always done well intended, and we often only consider what will be the outcome if it works. But using that wider formulation to consider if it doesn't, where that escalates to. There is a higher instance of RISH as a presentation in conditions like emotionally unstable personality disorder or complex post-traumatic stress disorder, where a minimal time in hospital is indicated. So thinking about, if you're to implement an intervention, how long that's likely to last, and how to withdraw that high level of support where we know that that's probably sort of a preferred outcome for the patient, really. A lot of that just draws back in on the medical intervention criteria, so considering the level of risk and the approach of the treating team. So again, the idea that the intervention needs to be proportionate to the risk, and where we would use clinical indicators to inform our meal plans, and not just patient reported information. As I said throughout, RISH isn't recognised as a diagnosable eating disorder, but the presentation and the risks associated of restricted eating are still best captured by the MEAD guidance. It's still the best fit. It is a mental health based framework. I don't know how Andrew goes about sharing the presentation, but the full MEAD guidance document, nobody wants to read, nobody's got time to read. It's a very, very vast document, but it is well signposted, and there are some great summary sheets at the end of the MEAD document. There are ones for community services, there are ones for psychiatric inpatient care, there are ones for lots of different practitioners, not just an eating disorder service or medical guidance at the back of those. If Andrew can share the presentation, if anybody wants it, the links are there. But I'll ask Andrew about how we go about doing that. And finally, where the two worlds meet, throughout the guidance that it does exist for RISH, where the risk is high, where weight is low, or there's weight loss, or there's evidence of significant physical compromise, it does very much talk about a collaboration with eating disorder services. The key is that that's in a consultative and supportive role rather than a primary treatment. An over focus on the eating being the primary need often detracts from the care that we want to be able to provide, and what's best likely to deliver a good outcome for the patient. So avoiding applying all the easy terms that we're used to, meal plans, focusing in on calorie targets for patients, but thinking about how to encourage patients to have what it is that they need, whilst offering that support with emotional regulation and managing those. Felt a bit whistle stop at the end. I was trying to talk desperately quickly. I'm pretty sure I omitted words at some point, but
That was really helpful. Thank you very much.
Yeah, thank you very much for it. Thank you very much. Does anyone have any final questions?
Martha, did you want to come in? I don't know if you heard Andrew say Martha or not.
I was wondering, I guess it's linked, but maybe on a bit of a tangent, but if there's certain areas don't have services for, say, for example, binge eating disorder, because I know that it's sort of relative to the other disorders, it's quite a new disorder. And I know that there are some areas in the country that still don't have services for binge eating disorder, and so would turn patients down. In those instances, can a patient exercise their right to choose, like you sometimes hear with some other services, and ask to be seen by MPFT, or how does that work?
The short answer is yes. Right to choose carries even more weight where there isn't access to treatment for a particular condition in area. People can exercise that right even if there is, but yeah, the short answer is yeah.
Okay, good to know. Thank you.
And the GP would just put the request in through to the ICB, but yeah, and it shouldn't be an issue.
Okay, thank you.
I think most services are beginning to add it now, though, because the community transformation was saying really all services have to offer a full spectrum of treatments, that they can't be making decisions based on BMI or cherry picking different eating disorders. So really all services should be offering treatments for all conditions now.
Yes, but I'm aware that in some areas, say for example Worcestershire, last time I checked, I think the services there were still very limited. So I think they had dietary advice, and I think there was like a DBT group, but there was no psychology, for example, no psychiatry for binge eating disorder, at least.
I think Brandon might be on the line, or he might have disappeared.
I knew you were going to hunt him.
Because I know a lot of the services have put in requests for via the provider collaborative for funding, so that they can start offering that full range of treatments. So I think a couple of years ago you'd be absolutely right, but every month at our board meeting more requests are coming in for funding for more comprehensive teams. So I think the tide is really turning in a positive way.
That's really good. Good to know. Thank you.
Working in a prison, how to refer and what support could we get for our clients? Prison is the unusual one around commissioning, isn't it? So we aren't our service. I've had this question before, and I do have a contact for somebody, but I can't think about it. I can't think of it off the top of my head. I've had this question a number of different times, but I think there is a mechanism to access some support. However, we are always happy for more bits of consultation and advice, and in a bit of signposting. We're always able to share those things, or resources. We'd be happy to do those.
Thank you all very much. Pleasure. Bye.